Hello, everyone. This is Dr. Hassan Hussain. I'm an assistant professor at Dalhousie University at the Department of Ophthalmology and Visual Sciences. And today we'll be talking about blepharoptosis, or more commonly known as ptosis. So ptosis is a very common condition that we often see in oculoplastic clinics. In this patient, you can see, as you look at the picture on the left, preoperative, and then on the right, a postoperative outcome. This patient had a posterior approach conjunctival Muller's muscle resection, and I'll be mentioning different ways of management at the end of this section. Other things to notice in these photos are some other involutional changes that we see, such as dramatic chalasis of the upper lid, prominence of the lower eyelid fat pads, and also the evidence of the inferior eyelid creases and the orbital grooves that we see with aging. So the first question whenever you are seeing a patient with ptosis in the clinic is, well, what is a ptosis? What is a blepharoptosis? So really it comes down to, of course, the subjective feeling of the patient saying that either both or one of their eyelids is droopy and interferes with their field of vision. But objectively speaking, a definition of blepharoptosis is really an MRD1, which is, as you know, the distance between the reflex from the pupil and the upper lid margin, that being less than between 2 to roughly 4 millimeters. However, there is some variability, of course, between people, and I have seen very young, younger people with an MRD1 of about 5 or 4.5, and it seems to be within normal limits for them. Of course, like I said, this is a very subjective thing, and patients may become symptomatic with as little a change as in 1 millimeter from their normal MRD1. And sometimes this is evident from old photos or pictures that the patient may have to show you on their phone and so forth. The next question you need to ask yourself is then, is it really a ptosis? So what you're seeing, is it true ptosis or pseudoptosis? And the reason that's important, and something that I always mention to residents in clinic, is that patients can often mask their ptosis, or they are confusing potentially, as we all might, the ptosis with some other issues, such as dramatic chalasis, brow ptosis, and then other more kind of difficult things to figure out sometimes, such as a contralateral lid retraction. So we were talking about definitions objectively of what a ptosis is, but if a patient has an MRD1 of, let's say, above 5 millimeters, then what they really have is an upper lid retraction on that side. And some people can get a contralateral lid ptosis due to a Herring's response. And that's very important to note. That is this patient presenting with actually a pathological upper lid retraction, and then they are noticing the other side being ptotic. Patients with enophthalmos, globe asymmetry, spastic disorders, aberrant nerve regeneration, Parinode syndrome, and floppy eyelid syndrome are other causes too. True ptosis, then we will divide into congenital and acquired causes. In this study from Baggio in 2002, their acquired causes seem to have a fairly even split between aponeurotic and myogenic causes. However, generally in practice, especially in sort of Western countries, epidemiologically, we're seeing more involutional aponeurotic changes. But if you were to go to other places, such as the Middle East or the Far East, those characteristics, of course, change. And the first thing we're going to talk about is, in a minute, congenital. So important to classify blepharoptosis. And, I have seen a nice way by Jeff Nerad, who described basically splitting ptosis into two types, into simple versus complex. So simple is congenital versus involutional, which is your involutional aponeurotic changes. Complex is all your other aponeurotic changes, neurogenic, myogenic, I've put neurogenic there twice, neuromuscular junction. And then we'll talk about management later on. So the reason we were talking about earlier about confusing ptosis with other presentations is this patient, for example, mentioned that his lids were droopy, but in fact what he has is very heavy brow ptosis. You can see that his forehead displays no evident frontalis rhytides because he gets very frequent Botox injections or botulinum toxin injections for migraines. And that has resulted in his brow becoming very heavy, and that is causing secondary dermatochalasis and the appearance of ptosis. But if you were to lift his brow manually, you would see actually that his lid is sitting at the appropriate position above the pupil. And this is just another example. These patients are very good, like I said, about masking their ptosis. So I always tell residents, you must ask the patient to relax their brow before you measure the MRD1. And that's sometimes very difficult. They're used to lifting their brow like I'm doing now all the time. And they can just present to you with headaches and brow heaviness as the day goes on, and they're just worried what's going on. What they're doing is overusing their frontalis muscle. So when you're doing the measurement, ask them to relax, then do the MRD1. This patient, we didn't touch the eyelids. He's got the evidence of dermatochalasis too, but we didn't touch the eyelids. We did a direct brow lift. And this is him post-operatively. I always aim for a overcorrection. But as you can see, his lids are sitting beautifully where they should be. The dermatochalasis, although still evident very mildly, has mostly gone. And his brow was the major problem for him. He was very happy. In fact, some of my happiest patients are the direct brow lift patients. So let's come to congenital ptosis. Congenital ptosis has been described as a dystrophy versus a dysgenesis of the levator muscle. There are some interesting papers debating this. I refer you to Ruth Manner's paper where they looked at the histopathology of these patients having levator resections. And what we're finding is that in congenital ptosis, in most children, they present with the levator muscle being replaced by a variable extent of fibrous and fatty tissue. So the levator function in patients who present early and sort of as a baby or early childhood, generally their levator function is either poor or moderate. Of course, the more severe their ptosis, the more likely their levator function is poorer. And they present with a typical finding of an absent upper lid crease, lid lag on down gaze, and sometimes they have other ophthalmological findings such as strabismus or amblyopia, which are very, very important to know about for their visual development. Of course, the ptosis, if it's causing an occlusion, a sensory deprivation, they will require early management. If we base our management of ptosis, basically I do that on how good their levator function is, their age, and whether it's bilateral. Those are the three main considerations. If it's bilateral with poor levator function, for example, I may have a low threshold for considering a frontalis sling. However, there are now papers from Spain about a frontalis pedicle flap done by a surgeon in Spain, which I'm interested in looking into, and that's something you may want to read about. I should mention at this point a condition called blepharophimosis ptosis epicanthus inversus syndrome, that's a mouthful, or BPES. This is an autosomal dominant disorder. This can come up in your exams. It presents with bilateral ptosis, usually poor levator function, blepharophimosis telecanthus, epicanthus inversus. So that's a fold of skin running upward and inward from the lower eyelid. It's very important to know your eyelid folds, and there's a good diagram in your Academy manual. There are two clinical subtypes, type 1 and type 2. Type 2 in females is associated with infertility due to primary ovarian failure. I'll let you check on what the gene involved is. That's a common exam question. Patients can also have other eyelid malpositions such as lower lid ectropion. There are other congenital conditions such as extraocular fibrosis syndromes, such as CFEOM, that can present as bilateral ptosis and a restrictive external ophthalmoplegia. Those patients, they're at higher risk of exposure keratopathy, so you have to be very careful with their frontalis suspension. Other conditions congenitally are myotonic dystrophy that you should know about, CPEO, which is a rare chronic progressive disorder with progressive symmetric paralysis of the EOMs. They also, interestingly, when you check their EOMs, they do not respond to oculocephalic or caloric stimulation. So those are basically, when you turn the patient's head or cause them undertake other tests, their eyes do not move as they would do without that condition. So these are mitochondrial conditions, very important to know about. I'm going to move on to aponeurotic ptosis. And like I said, the involutional causes are the most common, but there are other aponeurotic dehiscences that can be caused by cataract surgery. I, in fact, do consent my cataract patients. I do a little bit of cataract surgery. I say to them that there is a risk they may develop ptosis due to the eyelid speculum, and I encourage my colleagues to do the same. It can occur through eyelid trauma. It can occur through contact lens wear, particularly the harder lens wear, chronic rubbing, and floppy eyelid syndrome. Involutional ptosis, as you know, presents in the older age groups, and that is a ptosis which is constant in all positions of gaze. They get a lid drop as opposed to lid lag on down gaze. They have good levator function. They have a high skin crease, upper lid crease. They may have actually also an iris sign in some patients with a thin aponeurosis, and that's worth looking out for. Yeah, that's basically the iris being visible through the eyelid. Sometimes it's that thin, and that will tell you that surgery is, first of all, more risky because you are close to the eyeball, but also that the result might not be so successful. You may have to go very high on the levator muscle to get a good result. They also present with thinning of the eyelid, like I mentioned to you already. So the things to do in the clinic that I do with involutional ptosis is, of course, do your measurements, ensure that you are dealing with a ptosis and not a pseudotosis. Do your MRD1, do your Bell's reflex, your extraocular movements. I always check for the presence of diplopia. And remember, if a patient has ptosis, they may be masking their diplopia. So lift their eyelids and check if they have double vision. You do not want to give a patient double vision by fixing their ptosis. They won't thank you. And of course, if they have double vision, you will be looking for other things such as other causes like myasthenia gravis. Remember, mechanical ptosis, look for eyelid lesions which could be causing ptosis, or an orbital mass, which could be in the fornix causing a ptosis. And do your levator function by splinting the brow, check your brow position, check your globe position, do your slit lamp examination, including, if required, Schirmer's and your tear breakup time. And then basically, I always evert the upper lid and check on the inside to check for giant papillae or follicles that can be caused by long-term contact lens wear. And that will all determine how you manage these patients. Complex ptosis, that's another talk in itself. We'll just go through that quickly, but that can be conditions such as neurogenic ptosis. The important things are third cranial nerve palsy, very important if you see a patient with a fairly quick history with no significant variability. A variability is a very important question to ask in your history. And if they've presented with some defects of the extraocular muscle or motility issues, remember, a third nerve palsy may not present with any pupil abnormalities. They all need neuroimaging. You do not base your neuroimaging on whether the pupil is involved any longer. Your management of the third nerve palsy will depend on, of course, the patient presentation and what they're looking for, but that can be complex. That's another talk. Horner syndrome is one to consider. They usually have a very mild 1 to 2 millimeter ptosis with good levator function, and they do fairly well with a posterior conjunctival Muller's muscle resection. Remember, that is a resection, that is not a Mullerectomy. I have preceptors in Toronto who hate that term because you are not removing Muller's muscle, you are resecting it. You remove Muller's muscle or do a Mullerectomy for another procedure that is really for eyelid retraction in thyroid eye disease. Patients with Horner syndrome can present with, of course, anhidrosis and enophthalmos as well. And then other conditions such as myasthenia gravis, again, another talk, an autoimmune disorder caused by receptors to the caused by antibodies to the receptors of the acetylcholine, sorry, I beg your pardon, caused by antibodies to the acetylcholine receptors. Remember variability, remember your ICE test. And other things such as Marcus-Gunn syndrome, aberrant regeneration. We've talked about myasthenia gravis. I'll just quickly touch on a myogenic cause called OPMD, or oculopharyngeal muscular dystrophy. This is actually very common, or more common in French Canada. We see a fair amount in the Maritimes. These patients typically present over the age of 40, equal prevalence in males and females. It is a progressive condition. They present with ptosis, swallowing problems. Ask always about whether they take longer to finish their meals. Double vision, proximal muscle weakness or extremity pain, and a change in their voice, very classical, a dysphonia. Clinically, they can have reduced levator function, but they have preserved orbicularis and Bell's function. They have reduced palatal mobility, which is causing their dysphonia, and also the swallowing problem is caused by an impaired gag reflex and problems with the musculature around the esophagus. Very important condition to know about, because you have to look at the patient always as a whole, but in these patients, they can suffer from malnutrition as they find it difficult to eat solid foods, which gets worse over time. And it is important to get their general practitioner involved for dietary advice. So management of these patients, like I said, is based mainly on age, on levator function. I classify my management strategies as anterior versus posterior, and also levator versus non-levator surgery. And things you have to consider finally when you're talking about surgery, which hopefully we'll touch on again another day, are things like dry eye, double vision, Bell's reflex, and orbicularis function. These are very important things you must complete in your examination. Oculoplastics is a specialty which really heavily relies on the history, and the exam, of course, outside the stent lab is almost just as important as the stent lab examination. So always look at your patient as a whole, look at their whole face before you move to the stent lab. And that's the end of that section. Thank you.